Hi everyone, welcome back. This week we are going to be covering liver pathology. Hopefully you are listening to this PowerPoint first, and then our second PowerPoint will make a little bit more sense to you. We're going to kind of touch upon both PowerPoints in this lecture. The additional PowerPoint is taking liver imaging and liver pathology a step further. You're going to be seeing a lot of exams out at clinical that require what are called Dopplers. And we'll talk about that in that additional PowerPoint, and we're going to kind of briefly touch upon that in some of these pathologies. So hopefully you are listening to this PowerPoint first. We are going to get started with our typical physiologic processes. So what are some of the diseases and conditions that can happen specific to this organ? And what does that mean for us and our job? So a few things before we even get into those specific conditions, we need to be aware of laboratory values, especially for any type of physiologic process that's happening particular to an organ. A lot of abdominal ultrasounds that are ordered are going to be ordered because a patient had blood work and it said that they had elevated LFTs. Now, an LFT stands for liver function test, and that's just a simple blood draw that is testing these levels of standard enzymes in that patient's blood. So some of those things that we are testing for when we're doing an LFT is ALT, AST, ALP, all of these different enzymes that are mainly found in the liver. We're looking to see, does that patient, do those enzymes fall within the normal standard categories for that enzyme particular to this organ. We don't need to get into the details of like what each of these enzymes are, what each of them do. There is one thing that I will say that is a little bit different from these standard enzymes and things that we're testing on that LFT blood work, and that is going to be our prothrombin time and our alpha fetoprotein. So these are going to be a little bit different. Prothrombin time, it actually isn't necessarily looking specifically at the liver. It's mainly testing the patient and seeing how easily they coagulate. Now, this is very important when we are doing liver procedures and liver biopsies because we don't want to be doing an invasive procedure on a patient who has a really long clotting time, right? Because then we increase their chance of bleeding, we increase their chance of hemorrhage if we were to hit a vessel and cause that damage. So we want to make sure before we're doing any type of invasive, particularly liver procedures, that the patient has a normal prothrombin time. So if you're working in an invasive radiology department or a place where you're doing these procedures, you're oftentimes going to hear the nurses talking about the patient's PT value or their PT level. You're also going to hear usually PT in combination with INR, and that is the international normalized ratio. So that kind of goes hand in hand with our PT value. Again, just talking about how quickly that patient can clot. We don't want a patient to have too high of a PT-INR level or have too low. If we have a higher PT number, that means it takes the patient longer to clot. If we have a lower number, that means they clot too fast. So again, we want them to fall within a normal range. We don't need to get into the details of what those numeric values are, but just be aware that if you're going in to help with a liver biopsy, you're going to want to know the patient's PT-INR blood work before we start any type of procedure. Now, the other one, alpha fetoprotein, this is something that we're going to come back to when we are looking at OB. This is a protein that we are testing for through the baby's system. So we're actually doing blood work on the mom, but we're picking up traces of that fetal DNA and those proteins in that fetal DNA, and we can actually see if they have any kind of genetic abnormality from these levels of AFP. So we're going to be coming back to that in our OB semester. We normally should not be seeing AFP in a patient who is not pregnant, but you know there are crazier things that have happened, and sometimes we can see that in a female patient who is not currently pregnant. So we're not going to get into that can of worms, but we will be coming back to AFP in our OB class. These are all going to be all of these enzymes, ALT, AST, ALP, LDH, bilirubin, those are all going to be standard on an LFT test. And the PT or the PT-INR and the AFP, those are going to be additional types of non-routine blood work, depending on what the situation is. So we're doing and seeing LFT as an indication for an abdominal ultrasound all the time. So that's something that you should be aware of when you're looking at recs when you start, or requisitions when you start clinical. Now, our first physiologic process specific to the liver is going to be what we call fatty infiltration. And I've kind of talked about this here and there. I talked about it a little bit last semester. This is when we have this overwhelming accumulation of fatty triglycerides that get stuck within the functional cells of the liver. And this is pretty much mainly only contributed by dietary habits, and some medications can cause this as well. So this is something that is very easily preventable. It is a reversible type of condition. But if it goes untreated and we don't adjust the lifestyle of this condition, it can lead to cirrhosis and death of those liver cells or those hepatocytes. So it's not something that we just want to ignore because it's technically benign. It can turn into something more complicated down the road and something more serious. Now, when we're talking about dietary habits with fatty infiltration, we see this in very carb heavy cultures. So cultures that have a lot of pastas, breads, rice, like we see that this condition a lot in those populations. We actually see this more commonly in women because women tend to eat a more carb heavy diet than men do. Men are a little bit more into the protein diet. So we're seeing this a lot in women. But it can affect anyone equally. We also see this a lot in beer drinkers. It's a very carb heavy beverage. So it really is so sensitive to those lifestyle habits. Clinically, if the patient is still in that fatty infiltration stage of this diffuse disease, they're typically going to be asymptomatic, but we're going to pick up on it on that LFT blood work. We also can see a patient who has typically mild hepatomegaly, where their liver is a little bit larger than it should be. And we do want to correlate this to any previous testing that they've had done. So if they come in for abnormal or elevated LFT testing, we are going to be doing imaging for that patient, and say we find fatty infiltration on those images, that patient is pretty much going to be coming back yearly for some type of imaging or testing until they can get that condition under control, or until they can get it completely reversed. Now, on ultrasound, the liver could appear normal in size, but we may see that slight hepatomegaly. We are also going to see diffuse or focal increases in the liver tissue echogenicity. So we are going to see that liver starting to appear brighter and brighter depending on how severe the condition is for that patient. Now, as it gets more echogenic and more echogenic, it's going to make it harder for us to evaluate the hepatic vessels. So looking at the portal veins, the hepatic artery, that's going to become harder and harder the more echogenic this liver becomes. If we think about why that is, we have these triglyceride cells that are getting stuck in the functional cells of the liver, right? So we keep adding and adding and adding into this liver tissue. We're making it denser and denser and denser. It's becoming thicker and harder for that sound wave to travel through. So we're technically going to get less penetration. We're going to get more shadowing as we are sending that sound wave through that tissue. So let's take a look at what some of these scenarios can present as on ultrasound. So the main thing that we're going to see is the diffuse or the overall increase in echogenicity of the liver tissue. So that's going to be these two examples over here. Now, this picture on the left side of those two, we can see that that liver is starting to become a little bit more white, more echogenic, right? Our kidney looks very hypoechoic in comparison to that liver. We may think that that could potentially just be our gain settings, but we want to make sure that we are, deploying an appropriate level of gain or amount of gain while we're scanning so that we don't make this liver look normal when in fact it has diffuse fatty infiltration. Now, if we look at the picture on the right side, we can say, all right, whoa, it looks very different. It's really hard to penetrate. I'm not getting clear borders really anywhere in this liver. This might be a kidney right here, right? But we're not getting the penetration to really evaluate that area. These borders are very vague. Nothing is clear cut. And that is because that tissue has become so thick with that accumulation of those triglycerides that it can't penetrate through all of it. So these are both examples of the diffuse fatty infiltration, one a little bit more serious than the other. Now, if we look at the pictures on the left side of our screen, this is when we're looking at what is called fatty focal sparing. Sometimes you'll see an image in your textbook or even an image on Google, or you may see a text starting to annotate, and they put on the picture FFS. That stands for fatty focal sparing. Now that is exactly what it's saying. It's saying that there is a little area of this liver that has been spared from this fatty infiltration. So you're going to see that hyperechogenicity, you're going to see that liver starting to turn more echogenic, but then you're also going to see this potentially focal area where the echogenicity looks normal, right? Where it looks a little bit more like its hypoechoic self. That area of hypoechoic tissue that's being spared from that fatty infiltration is what we are terming the fatty focal sparing. So the picture on the bottom, this is pretty much what we see, this like little area of tissue that hasn't been invaded with that accumulation of triglycerides. So it's appearing normal in its echogenicity. Now the picture on top, it's almost like the liver has been like divided in half, right? So this would be the area of fatty infiltration. This is going to be the area of fatty focal sparing. So pretty self-explanatory, and we can see any combination or any kind of presentation of fatty infiltration. It's not going to look the same between, certain patients. Every patient has something that looks a little bit different with this type of diffuse disease. Now, moving into hepatitis, this is something that you have probably all heard of or maybe seen a commercial for. This is something that affects a lot of people, and it's inflammation of the liver parenchyma. So the functional cells of the liver are inflamed. We are seeing this in acute and chronic forms. Chronic forms, unfortunately, are going to be the patients that we see very often, kind of like fatty liver or fatty infiltration. We see these patients on a yearly basis. If you have acute hepatitis, you are going to have those elevated LFTs on your blood work. You could have nausea, vomiting, right upper quadrant pain, right? Because that's where our liver sits. You could potentially have a fever because there could be some type of infection that's causing this inflammation. We could have hepatomegaly because, as we know, when tissues get inflamed, they swell, they get bigger. We also could have jaundice. So the patient is going to appear slightly yellow in their coloring. Now, if you have chronic hepatitis, this means that you have either had multiple episodes of acute hepatitis or you've had ongoing hepatitis that persists for at least 3 months. These clinical symptoms are going to vary due to a wide range of causes. If you've had treatment that's failed, if you've had an infection that you've treated or you can't treat. So clinically, chronic hepatitis is going to be very different for each patient that has it. Treatments for hepatitis in general are really going to depend on the type. So we categorize hepatitis, yes, into acute and chronic, but we also categorize it on the type of hepatitis, meaning how did this patient get this inflammation? We commonly hear of types A and C, we hear of types B and C. but we also have A and E types. This all depends on the root cause. So did we get this from, blood transmission? Did we get this from food? Did we get it from water? Did we get it from an animal? Did we get it from some type of metallic exposure, right? So there's a bunch of different ways that we can contract hepatitis, and the way that we contract it is the way that we categorize it. Now, with types B and C, we try to treat any type of hepatitis, but these seem to be a little bit harder to treat, and we oftentimes are seeing these patients for a longer period of time. Type C, this is a viral contraction. So you can get this as an STI, you can get this from tattoos, you can get this really from anything that's coming in contact with somebody else's blood. And we can treat the patient with antiviral medications if they fall under the type C, Hep C. This is something that is extremely difficult for the patient undergoing these types of medications. These medications like completely wipe out your system. They like deplete you. It's a long process to undergo these antiviral medications. It's not guaranteed to work. They come with their, checklist of symptoms. So it's really hard. And a lot of times insurance companies aren't even covering it for the patient. So these patients are tired, they're frustrated, they're uncomfortable, they're sick. So we don't want to judge them. We don't care how they got hepatitis, right? That doesn't change anything. We're not going to be judging our patient for any lifestyle choices that they've made. We just need to make sure that we are doing our job to get the best information to help in that treatment process, and also empathize with what they are going through and understand what they are going through and how uncomfortable they must be in that scenario. On ultrasound, acute hepatitis is going to appear differently than chronic hepatitis. Acute, depending on how early it is, the liver itself may start to appear normal, and then we can kind of see a slight decrease in echogenicity. So the liver itself can start to appear a little bit more hypoechoic, and then we get these really hyperechoic portal vein walls, and that gives us what we call our starry sky appearance, and we have a good picture of that on our next slide. We also can start to see that slight hepatomegaly, and we can see some gallbladder wall thickening. Chronic hepatitis, the liver is going to appear brighter, so it's going to appear kind of close to fatty infiltration, but we're going to start seeing this coarse echo texture. So the tissue itself is going to start to get a little bit almost looking heterogeneous, a little bit more coarse and kind of bulky in its internal echo texture or architecture. The portal vein walls are going to appear hypoechoic, so we're not going to see that starry sky appearance. We could potentially see portal hypertension, which we're going to talk about a little bit today, and then also in that Doppler PowerPoint. And then we can also start to see an early cirrhotic appearance. So the longer we let anything go, especially when it's any type of itis, that can lead to tissue death, right? If we have chronic inflammation of tissue, we've talked about this before, the tissue is responding to this constant heat and it's constantly trying to overwork itself to get itself back to normal. So eventually it's going to be like, listen, I'm tired, like I'm done. I've got nothing left in me to give. So the cells are going to start to die off. And that's when we start to see this coarse echo texture come in, this kind of heterogeneity, this cirrhotic appearance is going to start to get a little bit smaller in size, right? So let's take a look at what some of these are going to look like on ultrasound. Here we have our acute. Now, if you're looking at the picture, especially on the left side, you're probably thinking, kind of just looks like a normal liver picture. And it does, right? So that acute hepatitis on ultrasound, we're not going to be getting like a ton of definitive information. We're mainly going off of that blood work. But what we can look at those portal vein walls. So if we're looking at our vessels, particularly on the image on the right side, we see echogenicity, right? All of these little punctate echogenic foci surrounding our vessels. That's going to give away that starry sky appearance, even as those portal veins start to branch off even further and smaller into the tissues there. So we're not seeing anything like overwhelmingly obvious when it comes to hepatitis, especially acute hepatitis. We're mainly going off of those clinical symptoms and that blood work. Now, when we have chronic, we're like, okay, this liver is starting to look a little bit different, but we could very easily confuse this with fatty infiltration. So we need to be going off of that blood work. We need to be going off of that patient clinical history, getting a good history from the patient, and seeing if this makes sense for a diagnosis. Now, if we look at the picture on the right side, we see it starting to become a little bit more hyperechoic. If we look at the picture on the left side, it's kind of looking a little bit small, right? If we were to do a measurement there, that looks a little bit on the smaller side. So we could say that that is that atrophy of that liver tissue. But another thing that we're looking for is the cirrhotic appearance, which we're going to be talking a little bit more about. But look at how not smooth that border is, right? If we look at the picture on the right side, that border is pretty much nice and smooth, right? But if we look at the picture on the left side, and I erase my drawing, that border is starting to look a little bit irregular, right? And that's where that cirrhotic appearance is coming in. So let's take a look at what cirrhosis is. So let's talk about it first. So this is an irreversible chronic degenerative disease. So this means once you have cirrhosis, you have it for good and it continues to get worse and worse and worse no matter what you do. So this is a very unfortunate condition to have, and undiagnosed and untreated fatty infiltration can lead to cirrhosis. So once you are in the diagnosis of cirrhosis, it does not ever get better. You can keep it where it is, you can prevent any further damage, but it's very likely that it is going to continue to progress and continue to degenerate over time until the liver basically no longer functions. So we want to make sure we're taking fatty liver very seriously, and we're treating it when we can to prevent it turning into this. So what happens with cirrhosis is the parenchymal tissue, so the liver functional cells and the functional tissue, start to die off because of this progressive, what we call fibrosis. And what happens with fibrosis is the tissue starts to kind of rapidly proliferate. And it's kind of like that fatty infiltration, right? We have more cells, more cells, more cells, more cells. But with progressive fibrosis, you have more cells, so the liver's trying to compensate for that. So now it's producing more fibrous cells, more fibrous cells, more fibrous cells. And basically, it's suffocating the cells that are trying to carry out the function of the liver. So the functional cells don't have as much room as they used to. They don't have as much space to conduct their business. So they start to say, look, I can't do my job under these conditions. So I'm going to start to die off because I can't do my job. So I'm just done. And then from there, it's going to be replaced with fat. So it's going to allow more of those fatty cells to come in and infiltrate that tissue. So basically, you are left with too much fatty infiltration, too much fibrosis, too many fibrotic cells, and not enough functional cells. So the cells that really matter can't do their job, so they die off, which ultimately is going to lead to liver failure down the road. Clinically, we are going to be seeing abnormal LFTs. We are going to see patients with jaundice. We are going to see them with hepatomegaly, depending on how early they have it. We'll talk about that in a second. And we are also going to see portal hypertension in cases of cirrhosis. Now, on ultrasound, again, it depends on which stage of cirrhosis you're in. Have you just fallen into the early cirrhosis category? Have you had cirrhosis for years? That is all going to matter when we are looking at this on ultrasound. So early cases, I guess we could say, early development of cirrhosis, we are going to see hepatomegaly, we're going to see fatty infiltration, and we're going to see surface nodularity. So that border is not going to be nice and smooth. Now, as that progresses further into the late stage cirrhosis, the liver is going to become smaller. It's going to atrophy on itself. It's going to become heterogeneous, right? Because we have all of these irregular amounts of fat and fibrosis and some leftover functional cells well. So we're not going to have that nice smooth presentation of tissue because the tissue is made up of all sorts of stuff that it normally shouldn't be. We are going to see that caudate lobe start to appear enlarged, and it's going to begin to compress upon that IVC, and we're going to see coarse echo texture and still that surface nodularity. Any stage of cirrhosis can have associated ascites with it, and this is going to be commonly associated with hepatocellular carcinoma. So if you have cirrhosis of any stage, you are at an increased risk of having this particular type of liver cancer, which we will talk about later on. When we are looking at a patient who has cirrhosis, it's really important for us to do a Doppler analysis. We will learn all about that in our next PowerPoint. But let's take a look at what these look like on ultrasound. So this top left picture, this is going to be that caudate lobe enlargement. You can see how it's really even compressing upon that IVC. This kind of looks like our splenic vein, not 100% sure, but we would have our IVC kind of coming down in this region here and really kind of encroaching on that area. Now, this picture underneath it, this is a really great example of showing us ascites, showing us surface nodularity, and showing us coarse echo texture. So here we have our ascites. This is our fluid collection that's accumulating around the liver. We're also looking at the surface of our liver so we can see that it's kind of very rough and irregular, lumpy, bumpy. And then we're looking at the echogenicity of that liver tissue itself. We can see that it's heterogeneous. It's not nice and smooth. It's very coarse in its appearance. And then here on the right side, again, we're looking at ascites accumulation. We have an irregular surface nodularity, and our liver is very small and also very echogenic, and gallbladder wall thickening. Let me erase this region here. Very thick gallbladder wall. Moving on to portal hypertension. This is a condition that occurs when we have this increased amount of pressure within the portal venous system caused by increased resistance. Now, a lot of things can cause that increased resistance. If there's a tumor in the liver and it's compressing upon any of those vessels, that's going to increase the resistance that the blood flow has to travel through, right? And it's going to increase that pressure because of it. When we have cirrhosis and we have that progressive fibrosis and we have those very thick, dense, heavy cells occupying a lot of the space in the liver, that's going to increase the resistance that the blood flow has to travel through. So a lot of conditions, tumors, pathologies can cause portal hypertension because they are they're causing the liver to resist the flow into it. So therefore, the blood system has to increase its pressure in order to get through all of those obstacles and those hurdles. We're going to talk more about it when we do our Doppler PowerPoint. Clinically, portal hypertension is going to be seen in association with numerous types of diseases and abnormalities. So clinically, it's all going to depend on what other things your patient has going on. If they have cirrhosis that's causing this portal hypertension, well, then they're going to have symptoms of cirrhosis. If they have a hepatocellular carcinoma that's blocking the pathway of the venous system, well, then they're going to have symptoms associated with that as well. On ultrasound, we are going to see that portal vein as it's entering into the liver have an increased diameter. So we're going to see a very dilated portal vein at the porta hepatis. We're also going to see it with abnormal Doppler flow patterns, which we'll learn about. We could see development of collaterals. Now, collaterals are very important in terms of maintaining our overall circulatory health. If we have a blockage of an artery anywhere in the body tries to make a detour around it. So when you have these conditions that your body is constantly having to fight against, it's just going to make a new pathway in order to keep you healthy, in order to get blood flow where it needs to be. So our liver is going to develop these collateral pathways to get around what is causing this resistance to create this increased pressure. We're also going to see this associated with ascites, and we could potentially see splenomegaly depending on the extent of how much this portal venous system has to increase its pressure. Remember, the portal venous system comes from the spleen, right? Our splenic vein is part of that portal venous system. So if it is, extensive in terms of portal hypertension, then we could see it backing all the way up to the spleen. We're going to talk about portal hypertension a little bit more. We have some pictures on our Doppler PowerPoint. So we'll get a little bit more information about that. We also have hemochromatosis. This is very rare, and it's when the patient has abnormal iron metabolism, so their body actually can't break down iron compounds, and it results in this excessive iron deposit throughout the entire body, and the liver is very sensitive to that. So we're going to see higher levels of iron pretty much in any organ in the body, but particularly we want to be looking for it in the liver as well. It also has a high association with preceding cirrhosis and portal hypertension. So if we see hemochromatosis, it is likely that that patient could get cirrhosis or portal hypertension in the future. Now, we have excessive iron deposits. They're sitting in the liver, right? They're causing that liver to prevent any blood flow to travel through it because there's more deposits in it than it should be, right? That liver tissue is now becoming thicker, becoming denser. It's, this iron is occupying more room, so it's going to create an increase in resistance to that portal venous system and cause that portal hypertension to have a higher amount of pressure to get through. So hopefully some of these things are kind of clicking together. Next, we have Budd-Chiari syndrome. This is something that we are going to talk about quite a bit throughout the entire program, even though it is pretty rare. It's a very serious condition that can be caused really by kind of two different things. It can be caused by any type of obstruction within the hepatic veins or the IVC, or it can be caused by this like membranous web, this like little membrane that covers the IVC at the junction of the hepatic veins. So it can present as either a clot in those vessels or like this congenital membrane that covers the IVC right at the junction of where the hepatic veins drain into it. Clinically, it's a pretty poor prognosis, and it all depends on the extent of whatever is causing that blockage. So if you have a blood clot or a thrombus that's causing the blockage, think of how close our hepatic veins drain into our IVC and how close that is to our heart. If you have a blood clot sitting right there, chances of it traveling to your heart and having a massive heart attack are very likely. So we don't want to ignore if we're seeing something that could potentially look like Budd-Chiari syndrome. Patient is going to have abdominal pain with potential vomiting and diarrhea. We could see severe ascites. We could see jaundice, hepatosplenomegaly, and we could have acute or chronic, again, depending on the severity of the obstruction and the type of obstruction. On ultrasound, we could see an enlarged caudate lobe with an atrophic or small right lobe of the liver. We could see thrombus within the hepatic vessels if that's where the obstruction is. Initially, the thrombus is going to appear hypoechoic, and as that thrombus becomes older, it's going to become more hyperechoic, heterogeneous, right? Remember we kind of briefly touched upon how tricky blood is in our previous PowerPoint? This is one of those scenarios. So if you have a thrombus, that's a blood clot, new thrombus, new blood clots are going to appear darker. So it's going to be a little bit harder to see, right? Because they're sitting in a vessel. Vessels are anechoic, they're fluid filled. So you're going to be looking for a hypoechoic mass and an anechoic structure. But as that blood gets older, as it coagulates more, it's going to become more hyperechoic, and it's going to kind of look like it's filling in the hepatic vessels, making it harder to evaluate. So let's take a look at what this could potentially look like on ultrasound. Now remember we said it's either the thrombus or obstruction of the hepatic veins or the IVC, or there's a membrane that covers the junction. These are two examples of types of thrombus that are making that blockage. So it's hard to really see the membrane if that were the scenario or the case. So these are two examples of when the thrombus is the obstruction. So here on the left side, we have our IVC here, right? And then we have our hepatic veins with our little arrows pointing to them. Now, if we look at this hepatic vein, kind of thinking like, it's not nice and anechoic, right? It's kind of like hard to see. Kind of just looks like a little crevice in there. That is all older thrombus occupying that entire branch of that hepatic vein. I want to say that that's the middle hepatic vein, but I'm not seeing it in relationship to the right hepatic vein, so I can't confidently say that. We can assume that that's the middle hepatic vein, and then this one is going to be our left hepatic vein here. So look how hard it is to really get a good, clear delineation of those hepatic vessels because that older, more hyperechoic clot is occupying the whole length of those vessels. Now on the right side of our screen, still an older type of clot. It's more hyperechoic, but this is a lot more focal. So right here is our entire obstruction. And that's really extending from the hepatic vessels into the IVC. Right, and our IVC is traveling up that way. So here we have our left, I would assume our middle, and then our right somewhere over here. This is probably a branch. That could be our middle and our right. Again, not 100% on the branching of the hepatics in these pictures because this looks like the right. It looks like they couldn't get the right hepatic on this image, so they did the right hepatic here. So that massive thrombus right here is posing major threats for that patient. Next, we have glycogen storage disease. This is kind of similar to hemochromatosis and fatty infiltration, where we just have these deposits of glycogen cells in the liver tissue. It's highly sensitive to enzyme defects, right? Our enzymes, the purpose of them is to break things down. So if there's something wrong with our enzymes or our enzyme levels, it's not going to be able to break down those glycogen cells. So they're just going to kind of sit and accumulate in the liver. Clinically, it's going to be variable depending on each patient, depending on the severity, how much glycogen is being deposited in the liver, how severe the enzyme defects are, all going to play a role in any clinical symptoms or LFT blood work. On ultrasound, the liver is going to appear echogenic, potential hepatomegaly, and also potential focal nodular hyperplasia. I think I have to add a slide about focal nodular hyperplasia. Yes, I do. Okay. So you can find an additional slide. I'm going to put it in the module for focal nodular hyperplasia. I knew I was forgetting something. But basically, glycogen storage disease is going to look very similar to fatty infiltration, to hemochromatosis, and we're really depending on those LFT levels to definitively diagnose between those types of physiologic processes that we see. We also could see a potential adenoma forming within the liver with glycogen storage disease. As we know, adenomas are benign tumors that can grow in any type of functional tissue. And this is one of the conditions that could cause that to happen. And here we have just a nice little chart that I threw together for you guys that would kind of be associated with the LFT blood work. This is something that you will be tested on your registry. They would potentially give you a question that your patient presents with elevated ALT and AST. What is the likely diagnosis? And you would have to know that that would be chronic hepatitis or cirrhosis or acute hepatitis. Yeah. So you would have to know the potential differential diagnosis depending on what information they're giving you. I'm not necessarily going to be as mean to say which condition is associated. Like, I'm not going to make you just pinpoint what enzyme goes with which condition. I'll give you some more context clues for you to be able to figure that out. But definitely come back to this chart and know that these levels you have to know for your registry, and then for me on a little bit of a lighter sense. Moving into pathology. So we're not talking about kind of any functional conditions with these. First is going to be our simple hepatic cysts, very self-explanatory. These are going to be congenital or acquired, meaning you could be born with it or you could just get one over time. They are not important. We're typically going to be seeing these either as one cyst or you could have a few in the liver. They're going to be asymptomatic. We don't treat them unless they are very, very large and they're causing surrounding issues because of how large they are. Then we can go in and drain it, but most likely will come back over time. On ultrasound, they're typically going to be an incidental finding. They're going to have nice thin echogenic walls. They're going to be anechoic with our normal posterior enhancement. So classic appearance of a cyst, and we don't worry about them when they are particularly in the liver. We don't want to confuse a cyst for the gallbladder. So it's another little tidbit when you're first finding pathology out at clinical. You know where the gallbladder sits. It's in that main lobar fissure. You can critically think through the difference between a gallbladder and a simple hepatic cyst. Moving into some of our nasty liver findings, we have a lot of abscesses that we are going to talk about. Now, abscesses we know form when there is something that has been untreated, right? So these are not something that are typically going to pop up overnight. It's something that are going to be manifesting for a number of different reasons for a little while, at least several days. A pyogenic abscess is also known as a bacterial abscess. Anytime we hear the prefix pyo, we're thinking pus, which is nasty. So this is a localized collection of pus that is located in the liver tissue. Clinically, we are going to see patients with fever, pain, pleuritic pain, which is that pleural space. So when they're breathing, they're going to be feeling that pain and that discomfort when they take a big breath in. We're going to see nausea, vomiting, diarrhea. We're going to see leukocytosis, those elevated white blood cell counts. We're going to see elevated LFTs, and we could potentially see anemia as well. On ultrasound, these are typically going to manifest in the right lobe of the liver. They are typically going to just be one collection of pus. They can be round and oval, but they also can be irregular with poorly defined walls. We're going to see variable echogenicity, possible acoustic enhancement depending on what the abscess is mainly made up of. We could see micro bubbles, which represent gas in the abscess. That's a very common thing for abscesses to do. They produce this byproduct of gas as they're manifesting. It's really gross. And then we could see calcifications as that abscess gets older and as it starts to heal. As we know, calcifications represent something that's been there for a while. Treatment. Oh, my Collaborate just did something funky. So hopefully you guys can still hear me. Treatment, we are going to aspirate and we are going to drain these abscesses and then we are going to put the patient on antibiotics. This is standard treatment for any abscess. Abscesses will not respond to antibiotics if they are too large and too powerful. So what you have to do is get the nastiness out, drain the abscess, get the junk out, and then treat it when it's small and when it's drained with antibiotics. The antibiotics can only do so much. It's like sending in a small little militia to like this national war, right? You wouldn't do that. You have to get the nasty junk out in order for the antibiotics to work. That is for an abscess anywhere in the body. Now, if you have a systemic infection, right, that you can put the patient on antibiotics right away because there's nothing that's accumulated at that point yet. Now, once it's gotten to the point of accumulating somewhere and you have an abscess, it's got to go first. Antibiotics won't do anything unless you get rid of it. So here we have our pyogenic liver abscesses. They're just very irregular. You could very easily confuse it with some type of solid mass as well. So we need to get a good, clear patient history, and we need to clinically be able to think through what the potential diagnosis could be. Next, we have an amoebic abscess. This is disgusting. All of these are just like skeeve me out. This is also known as a parasitic abscess. This is a localized cavity that's caused by a certain type of amoeba parasite. So you get some type of parasite from water, food, environmental, and it just kind of manifests in your liver. As you can tell, our liver is very sensitive for picking things up, right? Things like to just get deposited in there, things like to just sit there, hang out, make an abscess, make a pus pool. It's just, it's great. Clinically, patient will have pain, diarrhea, leukocytosis, abnormal LFTs. On ultrasound, kind of similar to the pyogenic abscess, it's going to just be variable in echogenicity, but it's mainly going to be located along the liver capsule. So basically you ingest this parasite gets into your system and it finds the liver because the liver is a sensitive organ, right? Everything filters through the liver and it basically just tries to get in the liver as quick as it can. So it goes right through the capsule, right through the border, through the wall, and just sits there and like makes itself at home there because it's the easiest place for it to just get in and just kind of grow and proliferate. Now here is what our amoebic abscess could potentially look like. Something that we like to keep our eye out for on an abscess is kind of looking for the distortion around it, especially when it's pretty large. This picture on the right side shows that a little bit better. So like see all of this tissue kind of around it. It almost looks like it's pushing the tissue in a ring around the abscess. And that's typically what they'll do. They'll kind of just compress the surrounding tissue as the abscess tries to grow. Okay, next we have, I will never make you guys spell this. I may make you say this just for fun, but we pronounce this term schistosomiasis. 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 Okay, so this is also known as snail fever. This is a type of parasitic worm that we get, so a little bit bigger than the amoebic abscess. This is an actual parasitic worm. This is not something that we see commonly in the US, but it actually is the second most common parasitic disease after malaria. So worldwide, if you take an international position somewhere, this is something that you could be seeing quite a bit. This is mainly something that we're getting from these infected snails that reside in this infectious dirty water. And you have to have direct contact with the water and your skin. So you go swimming in water that you don't know has these parasitic worms in them, you drink water, ugh, you wash your hands, anything like that, you run the risk of getting this snail fever or this parasitic worm. It's mainly going to affect the liver and the urinary system. I do think I have a video of this, so I will put it in the folder as well if you're interested in seeing it. Same thing with our amoebic abscess. I think I have a nice video of that as well. Next, we have hepatic candidiasis. So this is an infectious fungal disease caused by the fungus Candida. This is very not common, but it can very easily affect any immunosuppressed patient. So if you have a weakened immune system for whatever reason, lupus, rheumatoid arthritis, cancer treatment, anything like that, you could get this hepatic candidiasis more easily than a healthy patient could. Basically, the fungus invades the bloodstream. It can kind of go anywhere. So we hear of candidiasis as a systemic condition, but we're looking at it in terms of the liver if we're doing an abdominal exam. Clinically, the patient is going to have this chronic fever. We are going to see a neutropenic patient with rising white blood cell count, and that doesn't necessarily make sense. If they're neutropenic, they have a weakened system, right? So their white blood cell count is already going to be low to begin with, but if we see this increasing white blood cell count, we're going to say, wait a minute, they've got some kind of infection going on. We got to keep them in the normal range. We got to get those white cell counts back down where they should be. On ultrasound, we are going to see what are called bullseye target lesions or wheel within a wheel lesions. This just means that they are hypoechoic masses with an echogenic center. And let's take a look at what that looks like. So here we have all of these hypoechoic masses, all of our little arrows pointing to them with a slightly hyperechoic or echogenic center. Now, it's important, again, to get clinical history, especially if you're working with a cancer immunosuppressed patient. Metastatic disease can have a very similar bullseye appearance. So we don't want to confuse some type of fungal infection with metastatic spread. Patient clinical history is so, so important. So we need to know it looks like this, but it could be this depending on the patient history. Next, we have echinococcal cysts. These are also known as hydatid cysts. These are infectious cystic diseases that are very common in areas of the world that are big in farming. We don't typically see this in the US, even though we do have some farming populations. We're mainly going to see this in sheep farms or farms that have sheep on them. It's a tapeworm that lives in the intestines of of herding dogs, and then through the feces from the dog, the eggs somehow get ingested by the human. So, like, you're not washing your hands enough, and you're working on a farm. Ugh. As you can tell, I don't do well with these things. I'm a germaphobe majorly. On ultrasound, we are going to see these round masses with possible calcifications. We're going to see septations within those round masses, and it gives it what we call this honeycomb appearance, also called water lily or cyst within a cyst appearance. I like that term the best, cyst within a cyst. It's a little bit more self-explanatory. And then we can also see parent and daughter cysts. So basically, it's when you have a cystic area that is coming off of a main cystic area. So the parent is going to be a cystic lesion, and then the daughter cyst is going to be a protrusion that comes off of that original lesion. So I don't have any images of parent and daughter cysts. I will try to upload something, but on our next slide here, these are two examples of the honeycomb on the right side, and then the cyst within a cyst or water lily on the left side. So two different types of appearances, same type of infection. So again, sheep herding populations, the dogs that work on those farms are going to pick up these eggs and these parasites, and it's going to be transferred through their feces to the human that lives and works with them. Oof. Makes me want to go home and just give my dog a bath. All right, moving into our solid tumors. So we've talked about neoplasms and adenomas and kind of these general terms that we can give to some tumors. A neoplasm is kind of similar to an adenoma, kind of like a synonymous term. It's any new growth of tissue that kind of accumulates. So a focal new growth of tissue. Now, an adenoma is going to be benign, whereas a neoplasm can be benign or malignant. So if we're talking about neoplasma, most likely going to be benign. Neoplasm, most likely going to be malignant. So the terminology and the way that we write the words associated with a tumor can kind of point us in the direction of if it's going to be benign or malignant. Right? Anytime we see carcin, we're always going to think cancer. Anytime we see an ulma, we typically are going to think benign, or an asthma, we're going to think benign. The malignant terms are a little bit harsher in the way that we write them and pronounce them. So a benign neoplasm or neoplasma, these are typically going to grow focally, they don't spread anywhere, and they're going to compress the structures and the tissues that are around them or surrounding them. We've talked about that before too. Malignancies, cancers, they invade surrounding tissues because they're strong and they can. Benign tumors are just going to compress them as they grow because they can't invade them, right? They're not invasive, but as they grow, they just kind of spread and compress the surrounding tissues. Malignant neoplasms are going to easily metastasize by our bloodstream and by our lymphatic channels. So first benign tumor that we're talking about here is our cavernous hemangioma. So this is the most common benign neoplasm of the liver. These are large blood-filled cystic spaces. Clinically, these are very common in females, particularly in women who are on any type of hormones, so birth control. We see these in women who are recently pregnant. So they're very hormonally driven in female patients. They're going to be asymptomatic. a small percent of these hemangiomas, because they are a blood structure, can bleed, and that can cause some pain for the patient. Over time, they're going to slowly enlarge. And as anything benign starts to grow, it's going to undergo degeneration. So it's going to grow and grow and grow, and it's going to get older, older, older. And at some point, it's going to be like, oh, I'm old and tired. I'm done. I'm all set. So it's going to start to degenerate once it gets to a certain size or a certain age. And then from there, all of those cells are going to turn into fibrotic tissue. It's going to undergo fibrosis, and it's going to undergo that calcification that we see with older structures. So we can kind of tell the age of a hemangioma depending on those characteristics. On ultrasound, they are round, hyperechoic, homogeneous. They're typically small, so less than 3 centimeters in size, and we typically see more than one in a patient. We are going to see posterior enhancement, and then as we said, depending on the age of them, we can see that degeneration and that calcification process. Here we have 3 different types of appearances of these hemangiomas. So the image on the left side and then the image on the bottom right, that's pretty standard, hyperechoic, round, kind of oval in shape, kind of minding their own business, right? Kind of friendly looking. And then the picture on the top right, this is something that you might say, oh, that kind of like looks weird, right? Like it doesn't look like the other two. They're a little bit bigger. They're a little bit more irregular. They're, hyperechoic, but then they have like these hypoechoic central compartments. That is the classic appearance of a hemangioma that has grown to a certain size and then started to degenerate. So that internal composition of these larger hemangiomas, where we're seeing it starting to turn hypoechoic, heterogeneous, that is that degenerative process. We're seeing it start to change its echogenicity, start to become heterogeneous, start to become a little bit cystic in its appearance. So that is going to be a classic appearance of an enlarged hemangioma that is undergoing a degenerative process at that point. Next we have, oh, I don't have to add a slide. Perfect. For some reason, I thought I forgot to put this in here. Next, we have our focal nodular hyperplasia. This is going to be the second most common benign liver mass. This mass is made up of these Kupffer cells, hepatocytes, and biliary structures. So kind of like the very primitive makeup of the liver. All of those cells are going to kind of congregate in this one type of mass. And the only thing that makes it different than normal liver tissue is that it doesn't have hepatic triads or veins. So it doesn't really have an appropriate blood supply, drainage. We're not seeing like the typical portal vein, hepatic vein, bile duct with it, right? We don't see those normal triads, but it's made up, this mass is made up of those functional cells, those primitive structures. We're going to see these hyperplastic lesions arise from an area of a congenital malformation. So basically, we get this congregation of these functional cells because somewhere along the line of that liver developing, there was a little malformation in that region, right? So it was making liver tissue, making liver tissue, making liver tissue, and then all of a sudden, like this one little area was like, oh wait, I forgot something, right? I forgot my hepatic veins in that area. I forgot a hepatic triad in that area. So that abnormal area has now kind of created its own little mass and its own little bubble. Clinically, these are also going to be hormonally driven, and they're more common in women under 40. They're going to be asymptomatic. On ultrasound, focal nodular hyperplasia has a very difficult appearance for us to find. It's very subtle, and we'll see that on our next slide. But we can see these areas either one or multiple, right? Because chances are if you had like one malformation in an area of the liver while it was developing, you probably have another malformation somewhere else in the liver, right? So we're going to see multiple of these areas. They're going to be pretty well circumscribed masses. They're very isoechoic to the liver tissue, and that makes it really hard for us to find. It's made up of liver tissue. So it's blending right in with its surroundings. We could see a possible central hypoechoic component to those lesions. We're typically going to see these along the subcapsular area. So right on that inner border of the capsule, they're going to be small. They can start to displace the surrounding normal functional tissue and vessels. And then we can also see what's called a spoke wheel sign. So this is when we have an area where there is either peripheral, so blood flow around the outside of the vessel, or blood flow going into the vessel. So let's take a look at what this is going to look like. So here, let's look at the picture on the right side. If you take away the yellow arrow and you take away the caliper, do you think you'd probably pick that up? Chances are most likely not, because even a lot of seasoned techs would miss something like this. So here, and look, it's right along the subcapsular region of the liver, right? Because here's our border, here's our capsule. Right internal to that. It's isoechoic to the surrounding tissue. It's very discreet, very subtle. And there's one, so kind of classic sonographic appearance, as we previously said. Picture on the left side. Now this kind of looks just like the hemangioma that we talked about, right? And they're kind of prominent in the same young women, hormonally driven. So that would be a differential diagnosis for both of those. But that is that hypoechoic central component. And then up here, we have our spoke wheel appearance. So we have that peripheral flow that was going along the outer border, right? You see those blood vessels kind of going around that mass in a circle. And then it has the internal central vascularity, so the spoke wheel Doppler appearance. Next, we have hepatocellular carcinoma. So now we're getting into more of our malignancies here. This is also known as, confusingly, a hepatoma. So I just said that anything that ends in an oma is most likely benign. Keyword, most likely benign. So hepatocellular carcinoma, that is going to be a malignancy. A hepatoma is a malignancy. Sounds like adenoma, which is benign, but it is a cancerous mass. So HCC, hepatocellular carcinoma, it's the most common malignant tumor of the liver. It's a primary type of cancer, meaning this originates here. This cancer originates in the liver and can spread to other sites. So it's highly, highly invasive, and it actually can produce Budd-Chiari syndrome. So kind of a weird association there. It's also strongly going to be associated with any type of previous chronic liver disease. As we said earlier on, that cirrhosis can lead to hepatocellular carcinoma. Any type of hepatitis can lead to that as well. Aflatoxin, afloxetin. That is a type of breast cancer treatment. So, of course, anytime you have one type of cancer, you're at a higher risk for having another type of cancer. But typically, like if you were to have breast cancer, you would get that breast cancer to spread elsewhere in the body. You're not really going to get another new primary, but with hepatocellular carcinoma, you can, because of the treatment that you underwent for a different primary cancer. So hepatocellular carcinoma is really kind of, any cancer is serious, but very serious type of malignancy. We also can get this from hepatocarcinogens in our food. So as if we weren't worried enough about what we were eating and all of the ingredients that we don't know what they are in our food, unfortunately, there is a link to that. Clinically, there is a higher prevalence in Africa, Japan, and Southeast Asia, also in Italy and Greece. Not particularly sure why, especially when we get into our OB semester. There are a lot of prevalences in certain populations, but I don't particularly know the detailed genetic science behind that. But that is typically something that the registry would word, and they would say a 22-year-old woman from Greece comes in, blah, 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 so on and so forth. You would use those context clues to help you. Hepatocellular carcinoma is more common in males. We typically can see a large palpable or feel a large palpable mass on the patient. They're going to have hepatomegaly, and they're potentially going to have loss of appetite, weight loss, nausea, vomiting, a lot of clinical symptoms that go hand in hand with any type of malignancy or cancer. And here we have our ultrasound appearances of HCG. So as you can see, they HCC, as you can see, they get pretty large. Also can be pretty discrete. So like this one, we wouldn't want to confuse that with focal nodular hyperplasia, right? We wouldn't want to confuse this one with a hemangioma, a degenerating hemangioma. So all of these like look so similar to each other, but we need to use the clues that are given to us to help us piece that together. Same thing with this picture on the bottom right. That kind of looks like the hepatic candidiasis, right? The bullseye, the target appearance. So we don't want to just write something off because it looks like something else that we learned about. Next, we have a hepatoblastoma. So this is a pediatric thing that we need to be aware of. This is the third most common malignant tumor in children. And it's actually the infantile version of hepatocellular carcinoma. The majority of kids that are going to get a hepatoblastoma are going to be under 4, and the majority of them are under 1. So very sad and upsetting, but it's something that we need to be aware of, and it's something that ultrasound is really important for. We're not putting a 1-year-old or a 4-year-old in a CAT scan machine. So we need to make sure if we're working with pediatric patients that we are aware of this. On ultrasound, it's going to appear similar to the adult form, solid, large, mixed echogenicity depending on how large it gets and if it undergoes necrosis or hemorrhage, poorly defined margins, could have calcium deposits, again, depending on how old, or areas of cysts. It's not going to show diffuse infiltration, so this means that the rest of the liver is going to look normal. So here we have a pretty obvious ultrasound picture of this in a child. It is this whole region here. But again, we don't want to confuse that for a hemangioma or fatty infiltration in a 1-year-old. Not like we would ever assume that. But yeah, pretty unfortunate situation. That's usually a very big registry question, talking about the hepatoblastoma. Next, we have METs, or metastatic spread to the liver. So the liver and lungs are going to be the most common site of distant metastatic disease. And this means that it travels to the liver and to the lungs. So they are usually not going to be the primary site of cancer. We're typically going to get cancer somewhere else in the body and have it spread to our liver. Primary sites are going to be the colon, the breast, and the lungs. So the lungs really are getting it from all angles. Like they're just getting bombarded with cancer either in the lung tissue or from somewhere else to the lung tissue. But mainly breast cancer and gastrointestinal cancers are going to spread to our liver. It's going to be dependent on the type of cancer, of course, and the stage of initial diagnosis, which would affect the metastatic spread, particularly to the liver. Hepatocellular carcinoma has a really poor survival prognosis, and that is because as a primary, so we just said that the liver is usually a site for METs. It's not usually a prime location of cancer, but hepatocellular carcinoma is. That is going to spread to the pancreas, the stomach, and the esophagus. And basically, once those organs start to become affected by cancer, quality of life drastically decreases, and treatment options drastically decrease, especially with pancreatic cancer. Clinically, we are going to see abnormal LFTs, jaundice, weight loss, loss of appetite, nausea, vomiting, all those other classic symptoms that go hand in hand with cancer. And then the metastatic appearance on ultrasound, again, that bullseye appearance, we could have variations of that. So we could have a well-defined hypoechoic mass, like that top image there. We could see a well-defined echogenic mass, like the bottom left images or masses in that image. And then we could see diffuse distortion of normal tissues without a mass. So the tissue could start to just look really, really irregular, really lumpy, bumpy. We don't have an image of that on here. And it's typical to have multiple lesions throughout the liver. So chances are we're not just going to see one bullseye or one target, right? It's going to be pretty much several or multiple throughout the entire liver. And when we put color on these regions, they're going to be hypovascular. So they don't have a ton of vascularity supplying to them. And then lastly, we have lymphoma. So how does lymphoma affect the liver? Malignant neoplasms involving lymphocytes are going to proliferate within the lymph nodes. They can either be primary, so they're confined, or they can be secondary where they are involved. Typically, if we are seeing lymphoma spread to the liver, it's going to be a secondary type of lymphoma, right? Because it's involving other organs. It's going to be similar in clinical presentation and ultrasound appearance to metastatic disease. So we're going to be seeing those variable bullseye targets in the liver tissue. We're potentially seeing multiple of them throughout the liver tissue. So it's not very common that we're seeing lymphomas spread to the liver, but it is something that we need to be aware of, especially if we know that patient's clinical history and they're coming in for an abdominal exam. So lots of information on this PowerPoint. We are going to touch upon some of these topics a little bit more in depth in the abdominal PowerPoint. So if you are ready, you can hop right on over to that recording, but make sure you kind of understand all this material before you move into that lecture.